So it's a very basic presentation. The topic. Sorry, it's kind of. Let me share it again. Yeah, that should be fine. The speakers were blocking my screen, so I was not able to see my slides myself. So I had to minimize that. So the topic is frequently asked questions in refractive surgery for the general ophthalmologist. No financial interest in this presentation. So when we talk about refractive surgery, what are the options? The basic options are the laser-based options, surface ablation or PRK, LASIK, SMILE, or the lens-based treatment, either phakic IOL or a refractive lens exchange. So I will be concentrating on the first four. I'll be leaving out the refractive lens exchange. So when your patient is there for a refractive surgery, what do you need to look at preoperatively? You need to look at the visual acuity with and without correction, assess the refraction, if required, do a cycloplegic refraction. It's essential to look at the corneal shape by doing a corneal tomography preferably. Look at both the axial map, the anterior and posterior elevation, and the regional pachymetry. And most of the newer devices do give you some indices which tells you whether the topography map is normal or abnormal. And the abnormal values are usually highlighted in red. Look at the central corneal thickness, its location in relation to the center, whether it is displaced inferiorly. You evaluate the tear film and the ocular surface. Also dilate the pupil, look at the crystalline lens and the retina, especially the periphery, to look out for breaks or any weak areas in the retina. Also assess the ocular motility and the alignment to look for any phoreas which may be present. The laser-based procedures are usually contraindicated if you have an unstable refraction. That means in the past 6 months to 1 year, the patient has had change of glasses. You have any abnormalities in the cornea, especially ectatic disorders, thinning, abnormal sensation, or limbal stem cell deficiency with some vascularization, insufficient corneal thickness for the planned ablation depth. So if somebody coming with -8 and your corneal thickness is 500, definitely you may not want to consider a laser-based procedure. If there are any significant lens changes or coexisting glaucoma or uveitis, or any other uncontrolled external disease, just like we discussed, allergic conjunctivitis, somebody has that, or severe blepharitis or pre-existing severe dry eye, which will worsen after the laser procedure, so they may not be great candidates for laser refractive surgery. Any coexisting autoimmune or immune-mediated disease as well. And obviously, if the patient has unrealistic expectations from the procedure beyond what the procedure can deliver, then there may not be a suitable candidate. So once you decide that this patient is willing or fits into the category where you can do a laser-based procedure, an informed consent is extremely important, although the current data suggests that most of these procedures have a very high probability of successful outcome. It is still, on our part, we should inform the patient about the potential risk benefit and the alternatives that may be there among the various refractive surgery procedure. And also to emphasize the potential complications that may occur no matter how rare, and explain some of them which may be transient and some of them which can be permanent and result in loss of best corrected visual acuity. So basically, in the informed consent, the points that need to be discussed is the range of expected refractive outcome. Somebody coming with -10, and if you're doing a laser refractive surgery, the chances of a residual refractive error may be higher than somebody you're treating for -2. The limitation, especially with respect to presbyopia and the potential loss of uncorrected near vision, especially for myopes who are used to reading without having to wear glasses, it's important. If you are doing monovision, that also needs to be explained, and sometimes you need to give them a trial using contact lenses so they get to experience what monovision is. The various potential side effects and complications, whether sterile or microbial keratitis, the keratectasia which can occur in the long run, even night vision symptoms, fluctuation under low light condition, and the worsening or development of dry eye symptoms. And if the patient has a latent squint, sometimes that can become manifest. And if you're doing a procedure on the surface and patient has pre-existing epithelial abnormalities like a epithelial basement membrane dystrophy, there can be, recurrent corneal erosion syndrome, which can occur. The option of doing simultaneous bilateral surgery versus sequential surgery also should be discussed, and the future impact on the predictive accuracy of IOL calculation during cataract surgery should also be informed to the patient. Looking at PRK or surface ablation, it can correct a range of errors in myopia ranging from 0.75 to -8 diopters, hyperopia up to 3 diopters, and astigmatism up to 5 diopters. You can remove the epithelium mechanically or alcohol-assisted, or newer lasers have the trans-PRK. And often the adjunct therapy is used with topical mitomycin C to prevent haze, often used for a 15 to 30 seconds duration. However, this is an off-label use because the long-term effect of mitomycin on the endothelium is not yet proven. Post-operatively, especially if you're doing a PRK, besides using antibiotics for a week till the epithelium heals, topical steroids, usually softer steroids, may need to be continued. At least in my practice, I continue them for 4 months to reduce the incidence of haze. Topical lubricants are also required for 3 to 6 months, as the corneal sensation takes 4 to 8 weeks to recover, and patients do experience some amount of dry eye during this period. With surface ablation, there is significant amount of discomfort in the first couple of days, so patients would require some pain relief medications. If topical NSAIDs are prescribed to manage the pain, then you need to keep a watch on the epithelial healing, because in the absence of complete epithelial healing, topical NSAIDs can lead to corneal melts. People have described using sunglasses post-treatment to reduce UV exposure, as that may have a role in inducing the corneal haze. Most patients undergoing laser-based procedure should be provided with a record indicating the pre-op keratometry reading, the refraction, and so this would be helpful in the future whenever the patient requires a cataract surgery and the calculation of the intraocular lens. Complications which can occur, you can get overcorrection, undercorrection. Sometimes over a period of time, you can have regression of effect. There can be some glare or starburst halo, especially while driving at night. With PRK, you can get early or delayed onset haze. So this is something you need to watch out, and you need to treat appropriately using topical steroids. You can get corneal infiltrates, melting, and if not treated appropriately, you can have perforation as well. Corneal ectasia, although has the lowest risk in PRK compared to the other laser procedures, can occur, especially if there has been preoperative corneal abnormality which has been missed prior to the laser procedure. You can have reactivation of herpetic keratitis. Topical steroids, if we are using it for a longer duration, we need to watch out for the side effects, namely the rise in intraocular pressure and any lens changes. As I mentioned, you can have an impact on the ocular alignment with the correction of the refractive error, which may require further treatment. Thinner corneas may require correction of the measured IOP, and this is more so if the patient has any associated risk of glaucoma. So you need to be able to measure the IOP correctly with calculation. If you are going to do a retreatment, they should not be performed until the refraction is stable or the corneal haze has resolved. And this is, we usually look at the corneal tomography or the topography for stabilization, at least 6 months after the primary PRK surgery. And retreatment, if there is significant amount of haze, one should be careful if you are doing a retreatment, because if the primary treatment has induced a dense haze, it is likely that the repeat treatment can also induce a similar haze. Mitomycin C application in that situation can help reduce the recurrence, the recurrence of haze. LASIK is more acceptable due to the absence of pain post-operatively compared to surface ablation. It can correct a higher range, myopia up to 12 diopters. Although in current clinical practice, I seldom go beyond 8 to 10 diopters, looking at the amount of residual stromal bed that is left behind and our understanding of the risk of ectasia. Hyperopia, although the laser manufacturer the laser is approved for correction up to +6 diopters. In clinical practice, we do up to +3, because higher than that, although there is an initial good outcome, but we definitely see a lot of regression. Astigmatism up to 3 diopters gives very predictable results, but the correction can be performed up to 6 diopters. In LASIK, the flap can be corrected using microkeratome or with the femtosecond laser. If you're using a microkeratome, you need to watch out for keratometry values which are either too flat or too steep, because if you have flatter corneas less than 40, you can have free cap, and if you have steeper corneas more than 47, you can have increased chance of buttonholing. And you should always watch out pre-existing epithelial basement membrane dystrophy, because sometimes with the passage of the microkeratome, you can induce a time's up. Okay, I think I'm going quite slow. So coming to LASIK, the post-operative treatment is the same. You use steroids for a smaller duration of time. Outcomes are quite good. Almost in this recent study on the patient-reported outcomes with LASIK, 99% had 20/20 or better, and in the other group, they had 96%. Complications are flap-related with LASIK, mainly epithelial ingrowth, interface fluid. You can have lamellar keratitis. So these are all the complications you should be aware of and you should discuss with the patient. Small incision lenticular extraction can also correct myopia up to 10 diopters. Here the advantage is because the flap is not cut, your corneal nerves are preserved, so you have a lower incidence of dry eye, and the outcomes are quite similar to femtosecond LASIK. Phakic IOL gives a correction beyond the range of the laser procedures. You can correct up to -20 diopters of myopia, 10 diopters of hyperopia, and 6 diopters of astigmatism. You need an anterior chamber depth of more than 3 millimeters and normal endothelial cell counts. The procedure is potentially reversible, so that's one of the advantage, and no impact on the dry eye. And the corneal aberrations are also induced are minimal. And they have seen in this study also comparing both high myopia as with laser-based and phakic IOL, the less loss of best corrected vision with phakic IOL. Complications potential with intraocular surgery. You can have endophthalmitis, endothelial cell loss, cataract formation, chronic inflammation, pigment dispersion, raised IOL dislocation. So this is in short about all the refractive procedures and what you need to know in your clinical practice. Thank you for your patient hearing.